event begins from today. It is AIOS International Ophthalmic Conclave. We are joined by 12 societies from all over the world. And these international sessions will run over 3 days, and we have 150 international faculty with us. And all these luminaries would be enlightening you and educating you with their videos and with their presentations. So I would now request Professor Mahipal Sachdev, who is the president of All India Ophthalmological Society, to say a few words, and the chairperson, Dr. Amar Agarwal, also to say a few words following that.
Thank you very much, Namrata, and a warm welcome to this unique digital course, I would say, wherein we have 12 international societies collaborating with the All India Ophthalmological Society to get the best in the world, the best talent, I would say, in the world to talk about various aspects of ophthalmology. I think the COVID, despite whatever ravages it has done, the one good thing is that it has made us discover a new form of getting together and to spread the learning, academic awareness, etc., amongst the various ophthalmologists across the globe. I think the world, as it was said that the world is flat, so I think it has gone much more flatter this way. And we are able to listen to the experts sitting in the comfort of our offices or in our homes, and to assimilate the best of knowledge. So I think it's going to be a great session that we are going to have today, because we have the best of speakers who are there from across the globe. And I'm sure all the listeners and the delegates who are participating would gain a lot from this particular session. So this session is basically an AIOS, AAO ISRS symposium, and it is going to talk about anterior segment update, where we'll be talking about various methodologies, various anterior segment innovations as regards technology, techniques, etc. So without much ado, I will pass it on to Amar, who is also the chairperson with me for this particular session, to say a few words, and then we can start with the session, please. Thank you.
Thank you very much, Mahipal. First of all, I'd like to say that this is the brainchild of Namrata Sharma, who's doing such a great job with Mahipal and Rajesh Sinha. I think this combination of this trio, they have taken AIOS to another level, and getting all these societies together, especially the ISRS and the American Academy of Ophthalmology together, just to update all on the platform there. The ISRS Refractive Sub-Day, the whole program director is none other than Burkhard Dick, and with him is Dipender Dhaliwal, and then Jodh Mehta. And you also have Renato Ambrosio as the president of ISRS, and the entire American Academy Scientific Program, whole burden comes on Benny Jeng. So in other words, these people have so much of work on their hands, but still they're taking so much of time out so that they can come to this conclave and educate all of us. Saying that, thank you very much to the entire faculty and Namrata for this great conference you're conducting.
Thank you, Amar. And now I think we would hand over to Dr. Dipender Dhaliwal as well as Dr. Ashwin to take over from here. I think Dr. Burkhard will have to unshare the screen.
Okay, hi, welcome all to this very, very special society come together of sorts, where All India, the American Academy and ISRS are all coming together in a form that's never been done before, and probably COVID's one of the reasons for it. And the idea behind this was to bring everybody together on one platform and educate. And I think enough being said about that. We do have with us a great set of panelists, as well as some speakers. We have Farhad Hafezi, who's probably a little bit tied up with the technical issue, but he'll be joining us soon. Susan Jacob, Carolina, and Claudia. We also have Namrata, who will be kickstarting this session with Burkhard Dick, Benny Jeng, Jodh Mehta, Priya Narang, myself, Renato, and Ashraf. So I'd love to congratulate all the speakers as well as the panelists. And Namrata, the floor is all yours to kickstart this show with intraoperative OCT for anterior segment surgeries.
Thank you, Ashwin, for coordinating this session and for helping us to do this session. I would be talking to you about the intraoperative OCT guided anterior segment surgeries. And we begin with the cataract surgery first. So, even in cataract surgery, it has a very important role to play because when you're making incisions, for instance, you're making a side port or you're making a main wound, then you can actually see the level at which it is being made. For instance, here it is going to be a biplanar incision, and that can be seen. When you're doing the capsulorhexis, then you can actually see that there is a flap which is being created here with the help of the cystotone. And this is especially useful when you're doing it in hazy corneas, because even if you lose the flap underneath, you can see it from underneath the corneal haze. Then even the separation of the nucleus from the cortex, and when you're doing hydrodissection or hydrodelineation, you can actually see the disassembly of the nucleus in the intraop OCT. And this becomes useful when you're doing cases of posterior polar cataract. And again, whenever there is any, you can see that when you put viscoelastic after cleaning up the cortex, you can see that the PC is intact and it bows down. Subsequently, the intraocular lens implantation is done, and then when the viscoelastic is still there, the gap is quite a bit, and after the viscoelastic is removed, the gap between the IOL and the PC decreases. And again, when you are hydrating the wounds, you can actually see the hydration of the wounds, as well as you can see if there are small Desmet membrane detachments which may be there at the wound site. And then you know that you need to address them before you finally take a call. So you can see a small wound site Desmet DMD which is there, and so you put air bubble before you finally leave. Now, this is a case of posterior subcapsular cataract, and you have an intraop OCT microscope. You can see that there is a gap between the PC and the overlying cortex. And when you have a white cataract such as this, you can see that there are fluid clefts present. So when you give a nick on the anterior capsule, there will be no fluid which will come out. But if it is a white cataract, which is a little different, where the fluid is present, then you can see as soon as you give a nick, the fluid will come out. So here there are no fluid clefts present. And as soon as you give a nick, the fluid comes out. So when there are no fluid clefts present, you know that this can be expected. Now, this is a case of capsular distension syndrome, and notice the gap between the capsule and the lens. And then after when you remove that contracture rim, again, notice that it's bang on the posterior capsule and there is no gap between the IOL and the PC. So it helps to fine tune your surgery. Then if you do have a Desmet's membrane detachment such as here and you put air bubble, then if you didn't have this ASOCT, you would think that you are actually done, but actually you're not done because there's little gap which is present here. And so when you put the air bubble there, maintain some constant pressure for some time. And then you can see that the Desmet's membrane is stuck to the back of the cornea. And then you know that this is your final endpoint. Then again, this was a case referred for corneal transplantation, but you can see that there's a Desmet's membrane detachment there. And if you address that, then without having to do a endothelial keratoplasty, you can still get a clear cornea. It is very useful in cases of big bubble deep anterior lamellar keratoplasty because you can actually see when you do keratectomy and you inject air bubble, you can actually see that the Desmet's membrane falls back, as can be seen here. And as you give a nick on the overlying stromal layers, the Desmet's membrane marches forward towards the stroma as the air egresses out. Then as you again put the viscoelastic like a kangaroo's pouch, this falls back. And then the overlying stromal layers can be excised so that the bare Desmet stares at you over which the graft is put. Now, when you're doing a type 2 bubble, then also you can make out type 2 bubble will start from the periphery, will move towards the center. You just stop short here because you don't want it to go right up till there. Because if you do AC paracentesis, you can perforate the Desmet's membrane. Then following this, the paracentesis is done as is shown here. And there are not one bubble, but there are two bubbles which are present. Very nicely, Dr. Dua has described Dua's layer, and much of work has been done on this even by Dr. Amar Agarwal's group. So you can see that this type 2 bubble is pushed back, and then again the surgery can be done as was shown in the previous case. This is just to show visual acuity of 6.9, 6.12 in a case which was of Hurler's. and the patient is doing well without having to do an intraocular procedure, the patient still sees well. Then even in healed eye drops, it is very useful because you can see that where is the healed eye drops, it will tell you the site, do trephination, and just as you come to the area of the healed eye drops, move a little anteriorly, leave little bit of stroma, and because it is paracentral, you can see that the haze will shift a little paracentral. Here also this can be seen, but it doesn't make a difference as far as the results are concerned. The visual acuity is still good, and you have 52 microns of the tissue at that area of haze. Then again, in SLED, chemical injuries, it is very useful because you can actually make out where the pannus is and where the cornea is. So the dissection becomes a lot easier because in these cases, often the corneas may be thinner and you don't know what the underlying thickness is. And then little pieces of limbal lenticule can be placed onto the amniotic membrane. Now, this is a chemical injury case which healed on just SLED with a visual acuity of 6/6 and without having to do a corneal procedure. Then it is also useful in cases of desmetoceles, such as can be seen here post-operatively. Now, when you put a little bit of tissue that is here and you don't suture it, you can actually see that there's an apposition between the two edges, the graft and the host and the recipient. And this gap, when you know it is completely full, then it's completely opposed. That means that is the end point. Then even in hazy cornea such as this, when there's a DMD present and you can't see anything, you can still see it on the IOCT, and air bubble is then instilled. And once you instill that air bubble, the Desmet's membrane is attached, but still some amount of shallow DMD is still present. And when you do the drainage of the fluid from the top, then and put air bubble, then you know that it is attached. And it is very useful in hazy corneas because you can make out where it is going. Then in DSEC, especially in hazy corneas, which is so much common in our part of the world, you can still make out whether the graft is attached or not. And when there are submicroscopic spaces that are present, which otherwise are not visualized onto the operating microscope, we can see this. In ultra thin DSEC also, when sometimes the graft gets inverted, as is seen here by the configuration of the graft, and by flipping it, one can actually make out and reorient it into the correct direction. And this is the last bit on the DMEC. So the graft can be, of course, stained with the trypan blue dye. The peripherals can be removed. And here you don't actually need an intraop OCT microscope because you can see it because of the visualization and staining of the Desmet's membrane roll with the trypan blue. But it is useful in cases of host because if there are any remnants which are present, then one can make out and can address them on the intraop OCT microscope. Then this is the Desmet's membrane roll which is taken, is placed inside. You have to get that biceps curl up. This is upside down, and again flip it up, get it into the correct direction, and then the Desmet's membrane graft is attached, and you can't make out whether there's any graft which is present at the end of even week 1 or month 1. And this is PDEC, Dr. Amar Agarwal's brainchild. So one can see that there's a PDEC scroll which is present, stained with the trypan blue dye. Then this can be excised with the help of the Vanna scissor. And this is after getting a big bubble. And this is the graft which is there. And this is a case in which it is being done. This paper has already got accepted in Journal of Cataract and Refractive Surgery, the IOCT guided PDEC. So again, you can remove the Desmet's membrane, diseased Desmet's membrane, put it inside and get it into the correct configuration, and then get it into correct position after putting air bubble in there. I found it very useful for cases of lenticule problems, especially in smile, because you can take the patient immediately to intraop OCT microscope and you can see which side the lenticule is stuck, whether it is stuck onto the bed or it is stuck onto the cap. And then if there is a problem, especially if too much of needling has been done, then one can rescue this. So these are our publications on IOCT guided surgeries, and very recently we published a review article in Survey of Ophthalmology. And it is a very useful tool, and I'm sure there are going to be more modifications and there are going to be, it is going to become better in the coming future. So thank you very much for your kind attention.
Well, thank you so much, Dr. Namrata, and that was an impeccable presentation, I must say. To introduce the next, I have to first introduce my co-moderator, Dr. Dipinder Dhaliwal, who is actually such a sweet lady, and I really cherish moments with her. So, Dipinder, all on you now.
Ashwin and to the team. I mean, I am just so honored to be here. Namrata, that was an absolutely fabulous talk. You always teach us so much. And, you know, it's really just such an honor to be able to share some thoughts with you all in this amazing Indian meeting. You guys just take these meetings to another level. You really do. I mean, so many different halls, so much different programming. It truly is remarkable. So honored to be involved and so excited to hear the upcoming speakers. And thank you very much for including the International Society of Refractive Surgery and the AAO in this programming. So our next speaker is actually my co-director of the next year's ISRS meeting, the Refractive Subspecialty Day. He is the senior director for the meeting. So he's going to be leading the charge on our meeting, which is going to happen in New Orleans later this year. And with no further ado, I'd like to introduce Dr. Burkhard Dick from Germany, and he's going to teach us about Pinhole IOL, the small aperture IOL for normal and post-refractive cataracts. Please, Professor Dick.
Deep and Ashwin, it's a pleasure, dear colleagues, to share my know-how on the small aperture IOL, which is already known for many decades in the history, the benefit, and it was especially true if we look at experimental results that so many trials and experiments, etc., have shown that the small aperture that broadens the peak, so to say, of good visual acuity, decreases depth of focus, especially for slight myopic eyes more than hyperopic eyes. And of course, there is the Agarwal suggestion, which we'll hear later on, of pupilloplasty, which works extremely well in these odd eyes. But we also know this technology as corneal inlays, and did trials on the inlay camera beforehand, also in cataract eyes, with good results, by the way, which was astonishing to us because we didn't expect that to that extent. And there is the device that's called the IC8 IOL, which offers an opening of 1.36 millimeter aperture and has a mask in the hydrophobic acrylic IOL of a 3.23 millimeter diameter. And we prospectively implanted this device into the non-dominant eye and in the other eye, a monofocal IOL. And the results were extremely good. Patient satisfaction was high. And also even with binocular visual acuity with mesopic, without glare or with glare, it was a normal, were normal results. We also compared on a prospective randomized fashion the IC8 implantation versus the Symphony. And interestingly, the IC8 performed similarly to the Symphony, slightly better in terms of visual acuity, and definitely better in terms of photic phenomena, like in this case, halos, for example. And also the question, of course, arises if you implant the left eye, for example, if it's not the non-dominating eye, into one eye, and the patient is so happy, can I implant this device also in the second eye? Because usually you would say it's only for one eye, but you can. And if you as we did and published that, you see that you even boost the depth of focus for these patients to a greater amount. Here's the defocus curve, and see how broadened it is by bilateral implantation. And also interesting, of course, like Bobby Ang published that the lens is not only robust against deviation from target refraction, namely 1.5 diameter diopters will not be recognized by the patient, but also in terms of astigmatism, it is working extremely well up to 1.25 diopters. That is the cutting edge, so to say. Then there is a slight decrease stepwise in terms of the visual acuity. And also, especially, I think this lens technology is favorably for post-refractive eyes. For example, the greater number that's increasing over the next years after PRK and LASIK. And we also had good results in this case because it's so forgiving, this lens, and still giving the potential of decreasing aberrations and deviation from target refraction. As we all know, the biometry is difficult in these eyes. And of course, this lens produces less problems. But it's also interesting for post-RK, or for example, for inlays, or in the right upside picture, you see a traumatic eye with iris trauma, for example, where Ashwin, of course, and Amar Agarwal will suture the iris. But if you're not that talented in surgery like they are, it's easy to implant the lens because you don't have to do anything else. So that's also, and we have for the very odd eyes, we have the extra focus. This is a lens that has no optic that in terms of power, but it's only a blend, but it's implanted into the sulcus on top of the pseudophacus and can also help you get rid of problems in this regards. I have no financial interest in this implant, but for very rare eyes, it is of help, definitely. The interesting thing, through this IOL, you can do aberrometry, you can do fundoscopy, optos diagnosis. You can also do retinal surgery, which I did several times already through this lens and through the periphery for well-experienced surgeon. I would say it's not a big problem. The only issue is that depends also, of course, on your visualization system. In vitreoretinal surgery, what is more difficult is membrane peeling in the center. Yeah, but it is doable for an experienced surgeon. Then, having a look into the future, the company Roviak, which is a German company from Holger Lubachowski in Hanover, we are doing currently trials and lasering individual blends into the natural lens, because we know with the femtosecond laser, we are not inducing cataracts, yeah, but we can block light. And that is what we did in human eyes with clear lenses currently. We are doing this on a prospective fashion with different university centers in Germany currently with eye tracking, etc., and the exact decentration, individual size of the corneal, of the lenticular aperture. And I'm not able to share the results, but you can see here the lasing of a human eye that can see very well. And also interesting, the same company comes with another approach, and that is that they detected that it's possible to laser into a normal eye that is clear usually, this kind of blend after implantation. So in the line of sight and with an individual aperture diameter and a mask diameter that can also be individualized with a femtosecond laser. And I would say our estimation of the implanted lenses worldwide, more than 80% of all existing IOLs would be doable and feasible for this technology. So this is also interesting, as well as other approaches that come up by smaller companies now. We don't have the time to mention that, but the optical principle in this issue, if you implant it in the non-dominant eye, is so striking that it's definitely an old proven principle with new applications. And I mean, you can eradicate deviations from target refractions, as I said, irregularities and astigmatism. The uncorrected distance visual acuity is very good. It's superior to many other options. And also intermediate and near visual acuity is good. It's not comparable to a trifocal lens if you have a monolateral implantation, but it's good, definitely. And enhanced depth of focus is reliably improved with good quality of vision. minimal symptoms and high patient satisfaction. And the new options, I'm hoping to report on that next year at this meeting. And so thank you a lot for giving me the chance to sharing my impressions and my know-how here and listening to me. Thank you so much.
Thank you so much, Buck. That was absolutely special because it's very rare to come across technology that really, everybody is going to adopt it at some point of time in the future. Next up, I think we have none other than somebody who I look up to so much in corneal surgery, and the rest of the world really is eyeing his 2022. He's I think the Cornea Society's president as well. But we're looking forward to this discussion. What's new in endothelial keratoplasty? So Benny Jeng, all yours.
Thank you very much, Ashvin and Deep, for inviting me to participate in this session. And a special thank you to Namrata and the AIOS for inviting me, as well as involving the AAO in this very, very special meeting. So I was asked to talk about what's new in endothelial keratoplasty.
Benny, your mirror, this thing is coming here. Presenter view is coming to us.
Oh, I don't mean to do it that way. Let me see.
Oh, it's still presenter view.
A swap display, I'm guessing.
Let's see.
Swap display.
Is that better?
Perfect.
Okay, good. Excellent. Thank you. Okay, I apologize for that. So I don't have any financial disclosures. So I think to give any update, it's very important for us to just take a step back and remember how far we've come. And for those of us who have been in practice for a while, it's hard to imagine that 25, even just 20 years ago, people who came in with any corneal disease almost always got a PK, even for isolated endothelial disease. It was only 2 decades ago, not that long ago. And then 15 years ago, Desmet came around, and the average thickness for a graft at that point was probably 150 plus microns. And so this is one of my first Desmets here up in the upper right. And then, about 10 years ago, we started to get thinner and thinner. And now we have ultra thin Desmet. I usually do about 70 microns for my graft for that. And then about 5-7 years ago, Desmet started to hit the ground, and you can almost not even see the graft in this picture over here. So, when Desmet came, and up to about 3-5 years ago, there was a lot of controversy as to whether or not Desmet, with all its inherent learning curve and complications, was worth it compared to what we thought was a really good procedure, which is ultra thin DSEK. And there are a lot of observational studies, retrospective studies, looking at whether or not we should be concentrating on Desmet. And people ask for more data. And so in the last couple of years, we've actually had a couple of really good, smaller, but really good randomized trials looking at ultra-thin Desmet versus Desmet. This is the DETECT study from Jennifer Rose Nussbaumer in San Francisco. And this one, the European study, both looking at comparing the two. And they both found, in essence, that a higher percentage of patients with Desmet achieved better visual acuity, depending on which study you looked at. In the DETECT study, they found that Desmet gave better visual acuity in general, and it was faster to achieve that visual acuity. And then subsequent studies and secondary studies have shown that there's less higher order aberrations, there's faster recovery of vision, less graft rejection with Desmet. And so I think a lot of people who do endothelial keratoplasty will agree that Desmet really has come around, and this is the newest thing in endothelial keratoplasty. And in fact, if you look at the distribution of tissue for the US eye banks, you'll see this green line right here is Desmet. And so from 2015, it's been on the rise. If you want to look at the raw numbers here, total endothelial keratoplasty procedures continues to go up and has surpassed PK back in 2011. And Desmet numbers have slowly been going down, while the Desmet numbers from 2013 to 2019 have almost increased by 10-fold. And so Desmet is really taking off. If you look at the international eye banks, which have tissue supplied by US eye banks, similar finding. You can see that Desmet is on the rise here in green. So what's new for endothelial keratoplasty? Well, there's a lot of aspects of Desmet that are actually quite new, which I'm going to talk about. DSO is not really keratoplasty, and I'm not going to talk about it because Professor Mehta is going to talk about that right after me. Endothelial cell transplantation is relatively new. I'll say a word on that. PDEC, and it wouldn't be me if I didn't say one word at least about antifungals and storage media, which I'll do at the very end. Okay, so what of all these things are new about DMEC? Well, we started by injecting the graft into the eye. There are now many, many different ways of not only unfolding the graft, as has been alluded to earlier in Professor Sharma's talk, but also injecting the graft into the eye, or in this case, Donald Tan's technique of pulling the graft into the eye. So different ways of getting that graft through the wound. In the US, we are, a big innovation that's really been helping me is the fact that we can get pre-stained, pre-stripped, pre-loaded DMEC tissue. This is Mark Terry's description of that, and you can see the scrolled up DMEC tissue in the modified Jones tube. The CorneaGen offers a similar thing in a goiter cannula here. And basically you can get tissue arrive in your OR ready to inject into the eye. And that's been a huge source of efficiency for me anyway. Femtosecond laser assisted DMEC, an interesting concept. This is using the femtosecond laser to cut the donor. This paper by Vishal Janji. What I think is even more fascinating is using the femtosecond laser to create the scoring on the host, not on the donor, but on the host. And I think it's particularly useful in cases such as here, if previously failed PK, where we don't want to be too aggressive about scoring and stripping so that we don't disturb the old wound. But this particular study, though small retrospective, showed that by using the femtosecond laser to create a very circular scoring with no irregular edges and tags, actually led to a lower rate of rebubbling needed compared to a manual stripping of Desmet's membrane. So maybe we'll see more about femtosecond laser assisted DMEC. We've all seen Garrett Mellis's concept of using less tissue for a DMEC. So in this case, hemi-DMEC as he first proposed. And you can see here the semicircular graft here. And then even for Fuchs using quarter DMEC, and thereby possibly allowing one graft to be serving 4 different recipients. What I think has been a huge, huge progression for us is the learning curve for DMEC. And we've been able to overcome that because of our teaching ability. The simulation that Chris Salas here devised using these artificial anterior chamber with a latex diaphragm to simulate the anterior and posterior segment pressure dynamics has been really revolutionary to help us teach others how to do DMEC in a wet lab setting. And I think this has been very, very important. We use this when we do our Cornea Society wet labs. And teaching to get over the learning curve is essential. This is Sophie Deng and I went to China to teach DMEC. And now that we can't travel, what are we going to do? Well, necessity drives innovation. And so this is myself teaching virtually how to do DMEC surgery. And this was a Cornea Society function that was done in collaboration with Eversight. This is the wet lab that we teach every year to our US Cornea Fellows. And we couldn't travel. And so what happened was that Eversight actually sent these artificial anterior chambers, much like Chris Salas described, and DMEC tissue to the fellows, who brought them to their operating room, hooked up their iPhone to the microscope. And I could actually feel like I was sitting next to 2 different fellows and instructing them on where to tap and what to do with the anterior chamber fluid, and was able to get these 2 fellows to be able to learn how to do DMEC and unscroll that the tissue successfully. So this is very, very new, and I hope that we can expand our teaching efforts worldwide because of this technology. A word about endothelial cell culturing. This is technically replacing endothelial cells. And we've all seen Professor Kinishida's New England Journal paper that came out a couple of years ago, talking about how to inject these cells and having patients lay prone. But this year new is his publication of the 5-year follow-up, and 10 of his 11 first patients continue to do very, very well after this was done. You can see here an example of the cornea cleared. I'd be remiss if I didn't talk about Professor Agarwal's pre-Desmet's endothelial keratoplasty. This is not a new concept. This was conceived many years ago using the big bubble technique to create a type 1 bubble, allows us to use potentially younger tissue and easier handling inside the eye. And, you know, we've had some different ways of optimizing doing this technique, and this is relatively new as well. And then finally, again, it wouldn't be me if I didn't talk about antifungals. I think that there's still a lot of research to be done, and there's still some debate. I obviously vote on the side of considering adding antifungal, but I'm not 100% sure exactly which antifungal nor which concentration is best. However, what is new is that a major eye bank in the US does actually offer the addition of an antifungal into commercially available fluid for storage prior to endothelial keratoplasty. So in conclusion, I think that a lot of new things have come around for replacing the corneal endothelium, specifically for DMEC. There's a lot of innovations, and the biggest one I think is that we can teach it virtually. We've proven that we can. PDEC is becoming a little bit more popular. Corneal endothelial cell transplantation is coming, and the antifungal debate continues. More research is needed, but I'm excited for all of these things to see what's going to happen even in just the next year. So I want to thank the organizers once again for inviting me to be here today. It's a pleasure, and so far it's been a wonderful conference.
Thank you, Benny Jeng. Again, that was masterful. Lovely, lovely description of what's new. And I have to say that I was also lucky to participate in the Cornea Society Fellows Virtual DMEC Wet Labs. And honestly, I felt it was easier to teach because we could sit at our desk and not lean over in microscopes and our neck wasn't hurting, and really give these fellows, you know, one-on-one or one-on-two attention and really look at each step of the way. So I agree. I hope that we can do kind of a global effort to teach DMEC virtually. It really worked well. So our next speaker is really another superstar in the field of cornea anterior segment. And he's going to convince us that we don't need corneal tissue at all, that the corneal endothelium can heal itself. So Jodhbir Mehta comes to us from Singapore, and he will be discussing desmetorexis without endothelial keratoplasty, or as we call it, Desmet stripping only.
Great. Thanks, Deepinder. Thanks, Ashwin, for the kind invitation to partake in this great symposium with a lot of our friends that we're finally seeing, at least online anyway, for 2021. So I'm going to be talking about DSO. I think this leads on nicely from Benny's talk as well. Great. Okay, so I'm going to be talking about DSO. As Deepinder quite rightly said, that really the acronym is really DSO, not really desmetorexis without endothelial keratoplasty. And I think this is one of the things that will probably change over the next few years, where we stick to a specific nomenclature of actually what the surgery is. These are my disclosures. They don't really pertain to what we're talking about. Maybe trefoil at the bottom, I'll talk about on the last slide in a little bit more detail as well. So DMEC, as Benny has shown, has really revolutionized the way we perform corneal endothelial surgery. We're getting better visual acuity outcomes, lower rejection rates, and less glaucoma. And there are different ways of performing the procedure. The endothelial outway is the technique that most people basically use. We use an endothelial in technique where the graft is pulled inside the eye with a pair of 27 gauge forceps and then tapped basically just gently on the surface to open the graft in its correct orientation. But the problem with both these surgical procedures is that they do require a considerable level of expertise in surgery. You do need reasonably good quality tissue to actually perform DMEC. And obviously we know worldwide, there is a worldwide shortage of corneal tissue, and 50% of people in the world have no access to tissue. And this is compounded by an aging population and an increasing global population. So we have to look at alternatives basically when we go forward. If you look at the three leading indications for endothelial disease around the world, there's Fuchs, there's bullous keratopathy, and there's basically regrafting for graft failure or late endothelial failure following penetrating keratoplasty. And these are the future concepts for replacement, really divided them into regenerative therapy or tissue engineering cell therapy. And Fuchs is really an interesting disease.
The two main concepts.
Fuchs is a great example. So Fuchs is a really great example of a condition where we can think about regenerative medicine approaches, because you have early disease and you have basically late disease. Early disease, the disease is really localized to the central area. And in these kind of patients, one can consider a regenerative therapy approach, while when there's more widespread diseases and much more endothelial failure, you need to think of a more cell-based therapy approach. And this is an example of basically going through basically a DSO procedure, and basically why we basically need to remove the central area in somebody who has basically early Fuchs. So you can see basically from the video, you can use basically a keratocone to access the anterior chamber. Viscoelastic is basically placed in. And then this is the original technique. This is an old video from a few years back now, where we're doing gentle basically scoring of the Desmet membrane before basically peeling the area of high density guttata away basically from the central area. I'll talk a little bit about modifications in the technique in subsequent slides when we look about issues with respect to improving outcomes of the surgery as well. It's much better to peel the tissue in the central area. These are some small gauge forceps to help with the basically peeling. It allows you to get much better control of the size of the recesses, which is basically important with respect to visual recovery. And also it ensures you don't dig into the stroma like when we're doing a standard Desmet for a DMEC surgery. So this concept is not really new at all. And this is a great picture taken from the Mass Ionia library that was basically sent to by Roberto. And you can see that actually back in quite some time ago, Pafik basically described a technique where he decided to basically peel off the posterior part of basically a corneal endothelium. And it's interesting, if you look at this, basically figure 71 over here itself, he puts down after the first stretching, after 24 hours, one is struck by the existence of morbid edema of the cornea. So I like the word of the use morbid here. But if you carry on this, it says slowly the edema is reabsorbed and the cornea regains its normal thickness. And in the same time as transparency begins, at least partially within 1 to basically 3 months. So as in many things, I see that in ophthalmology or even in medicine, you know, this has been described by some of the great pioneers basically in the past. And this book was published in 1955. So we have to do basically, you have to bear this in mind. Now, which are the patients that are ideal for this disease? Well, any of these patients on the right-hand side over here, you can see that we can consider basically having early Fuchs. And when you can basically map out the area of central sclerotic scatter around the area of the guttata, these are your typical patients that will ideally basically do well to think of basically doing a DSO surgical technique. And primarily because the disease is localized to the central area, but the paracentral endothelial cells are actually quite healthy. And that's what you're going to basically rely to basically migrate across the surface. If you have widespread disease, like basically this one below over here, you can see there's a lot of basically scarring over here. This patient will have to undergo basically conventional DMEC surgery. So it allows you to look at your early Fuchs in a lot more detail because we have an alternative therapy that we basically didn't have in the past. This is one of the first papers. This is from Greg Maloney, published a few years back now, looking at 12 eyes, where he basically did essential DSO, a Desmet stripping of basically 4 millimeters. And you can see basically from his initial cohort, 9 out of 12 cleared between 2 to basically 6 months. And there's an improvement in visual acuity in basically all cases. One basically did not clear at all, even with the addition of a ROCK inhibitor, which we'll talk about in a little more detail, and had to subsequently undergo EK surgery. And 2 eyes basically stalled at 3 months, and they underwent topical rapacidil, which is a more commercially available ROCK inhibitor. And this basically had clear central clearance. And the postoperative endothelial cell counts were between about 500 to basically 1299. This is one of the first reasonably large series, or albeit pilot series, of about 12 cases that really showed this basically technique work. But it also showed that in certain cases when the basically migration stalled, one required the use of basically ROCK inhibitors. This is just some examples from the paper where you can see that basically central edema or morbid edema, as Pofik basically described. And then you can see basically as the corneal cleared up, it becomes less morbid and much more transparent, as we're all basically used to. So I just wanted to mention a little bit about ROCK inhibitors. So what is basically a ROCK inhibitor? So the ROCK protein, it's a serokinase, and it's basically involved in multiple basically cellular functions. The Rho-ROCK pathway is involved in cytoskeletal functions, affects cell migration, cell cycle control, proliferation, and apoptosis. The thing is that when you apply a ROCK inhibitor to an individual cell, you're going to get a difference in result depending on the cell type. There are 2 basically enzymes of ROCK1 and basically ROCK2. They have 90% homology. But interestingly, if you look at the expression in the corneal endothelial cells, you have higher levels of ROC1 compared to ROC2, but overall in the eye over here, you have higher levels of ROC2 over ROC1. So the endothelium shows a difference in expression compared to what we basically see in the rest of the eye. And this is important when you're looking at selective inhibitors or non-selective inhibitors with respect to basically function going forward. We know endothelial cells are actually contact inhibited, and they're basically in a G1 phase. And we know there's TGF-beta2 in the aqueous humor, but basically prevents cells from actually basically proliferating itself. So what you want to do with the ROC inhibitor is actually to knock the cells out of this G1 phase. And this is done by altering these, what we call negative regulators of the cell cycling. So typically cycling 1D1 to D3 ratio, and also basically reducing the effect of P27. And this allows your cells to transit from G1 into S1 phase and into basically cellular proliferation. And all of this work was done by Professor Kinoshita and Noriko Kozumi's group in Kyoto between 2009 and 2013. And they were the first to show the effects of ROC inhibitor on basically monkey and rabbit corneal endothelial cells. So interestingly, after that, people obviously tried to start basically using it on human cells, but the results were actually quite variable. And this is one of our papers basically showing the effect of donor to donor variation, showing the variation in the ROC inhibitor. And this is why sometimes you'll see some effect in some patients, but you won't see basically set effects in basically other patients. And when you study the effect, when you do it ex vivo on human donor corneas, you can see that you get faster migration rates by using the ROC inhibitor compared to basically non-using ROC inhibitor in age-matched donor pair control groups. And so you do get an increased migration speed by the use of ROC inhibitor, but this is more prominent in older patients compared to basically younger donors. So this is the summary of basically using a ROC inhibitor. We can use it for cell expansion, for human endothelial cells. They prevent basically cell death. This is primarily related to corneal endothelial cells. They promote improved cell adhesion, and they increase cell migration and in regenerative basically therapy treatments. And the first use of ROC inhibitor was done by Professor Kinoshita's group, where they had one patient with Fuchs, where they used transcorneal sclering in the center over here, and then applied Y237632, which is your archetypal ROC inhibitor, and you can see nice clearing basically of the central cornea. But the problem with this is that, of course, the cells have to migrate, and if you don't remove the guttata, then basically the cells are going to get stuck as you're going to migrate across the central area. And using basically experimental models of the guttata, you can basically show that you need to remove the guttata to basically improve the cell migration. Likewise, you can see this on ex vivo corneas, that if you apply ROC inhibitor onto the surface, you get a much more even cellular migration of your cells. So do ROC inhibitors work clinically? Well, the answer is yes. There's two papers from here, one from Greg Maloney's group and one from Mario Masrai, where you can see the comparison in study 1, where no ROC inhibitor was applied, but this is Rapacitol being used in this group, compared to a group basically with Rapacitol. And what you can see, the clearance time improved from 13.8 weeks down to basically 4.3 in Greg Maloney's group, and likewise very similar results between faster recovery, 4.6 weeks versus 6.5 weeks in the group without the ROC inhibitor. There was one non-clearance in basically Greg's group and one non-clearance in basically in Marianne's group. So it doesn't necessarily work in every single case. There are some side effects you will see. You will see some cytosolial changes on the epithelium, which I'll basically show you. And if you do get systemic absorption, you can get ocular discomfort and basically hyperemia as well. This is one of the side effects that you often can basically see on the surface. You can see this typical honeycomb epitheliopathy, and you see this especially if they're using high dose levels of basically ROC inhibitor. And likewise, you can also basically see once the cells basically are formed, you can see the pseudoguttae formation on the endothelium over here. And this is the same representation on in vivo confocal microscopy, but this is basically what it looks like clinically. If you dig into the stroma, as I basically mentioned with the technique, initially, most people were basically using Sinskey hooks, and you disturb the underlying stromal matrix, you will get these nebula of scarring over here itself. And that's because you're stimulating the underlying or posterior stromal keratocytes. And that's why you're basically going to scarring around the edge. And that's why it's safer not to use basically a hook to do your scoring. It's better to basically use some forceps. So in summary, corneal transplantation for endothelial stains has dramatically changed over the last 2 decades. We've seen a shift from PK, obviously, to basically to EK, with less complications, better visual acuity outcomes, and less risk of rejection. Despite this, when we look at this more holistically, and we know Fuchs is the leading indication for corneal endothelial transplantation in the United States, we're looking at newer disruptive techniques in regenerative medicine, basically is at the forefront of this, especially for Fuchs, where we can get even better outcomes in selective patients with corneal endothelial disease. When you're looking at DSO, centration is important because, of course, the new optical zone is going to be formed from your basically stripping. Sizing is important. You need to peel, not basically scrape, because it will basically affect your cell migration. And of course, you still need to counsel for the chance of a graft and counsel the patient how this basically techniques will work. So I tell patients that generally this is a regenerative therapy technique, so it will depend on your old cells to migrate. There are newer drops under investigation. One of these is made by a company called Trefoil that I mentioned basically at the beginning. They're undergoing phase 1, phase 2 trials in the United States currently now. And I think we will see more drops coming to this arena in the future that will actually increase our endothelial cell migration speeds that we actually will avoid doing full thickness of endothelial keratoplasty for in the future. Thank you for your attention.
Wow. Joe, you stole the show, buddy. I must say. But I think everybody would be rest assured that we all learned something today, and I know I did from this presentation for sure. Important topic is I always thought that peeling is only for retina surgeons, but now I think we all have to learn peeling of the corneal tissue as well. So thank you for that splendid presentation, Jodhbir. Moving on to our next presentation, it is something new and innovative as well on perimetry or virtual perimetry. And I think none other than Priya Narang is going to be talking to us about this. So Priya, all yours. Priya, you're on mute. You're on mute. Priya, can you hear us? You're on mute. Okay, I just didn't know that.
Sorry, the unmute button, it was not getting unmuted. That was the issue right there. Oh. I think there's an issue here. Is this visible?
Perfect, perfect.
I'm sorry for this. So thank you so much, Dr. Namrata, and for having me here. And it's great to be in this international conclave. And I'll be covering up the virtual perimetry. Virtual perimeters, they are actually, they are the in thing, and the recent developments, lots of recent developments have occurred in this field. There's a continuous evolution of portable visual field tests that are going on, and the emerging tablets, the computers, and the internet-based diagnostic procedures have come up. Many other approaches have also been introduced in this era, and the visual field test is dawning, and the virtual reality headsets, this is something which is a game changer when it comes to perimetry for two reasons: that they have an ability to control the fixation, and the distance from the eye to the screen is fixed. Hence, there is no variability that comes up with the device in itself. And the virtual reality headsets, they also solve the fixation issues because they do have a gaze tracking system out there in them. So the virtual perimetry that is usually done these days comes up with the virtual reality headsets, although there is a lot of description in the peer-reviewed various devices they have been used, like tablets, iPads, etc. They have been used currently. The availability of the portable devices, they are very inexpensive and battery operated devices. They that can interface with the telemedicine programs. They should be tremendously beneficial for vision testing in the developing countries. And they have the ability to conduct these tests in a waiting room also. And therefore, this can be really beneficial. It can be cost effective, time saving also for the surgeons. So these are different kind of literatures that are there in the peer-reviewed in the peer review. most of them are basically the subjective tests wherein, the patient has to click the button when you see the visual stimulus. And N-Goggle, which has been described, that's a portable brain-computer interface, and it detects the visual function through the electrical responses that come up in the visual cortex. So there is also the online perimetry tests which have been described, the Peristat, which was recently published last year. Coming up to something new that I would like to introduce is the advanced vision analyzer. This is a newer device in the horizon and by the ELISA vision technology. I'd like to discuss on this because I have been using it for quite a while, and I have also been a part of coming up with the nomograms for this device. So this AVA is a virtual reality automated perimeter. You can see these are the basic four parts of this, the constituents, the head-mounted device. On the left, what you see is the patient response pattern. The test control device, it's a tablet, which you see on the right. And the fourth is the backend cloud server, which helps to store the data and transfer the data. And you can also retrieve it as and when you need it. So some of the key features that I would like to highlight about this newer virtual reality headset perimeter is that it offers white-on-white perimetry, and it has an eye tracking system, that helps to track for the movements. You can adjust the interpupillary distance, you can place the corrective lenses and correct the refractive error of the eyes that are being tested. The stimuli that is used in this is the standard Goldman size 3. And there are various catch trials that have been incorporated into the device, and they are conducted periodically after every 10 stimuli presentations. And the test strategy, it keeps on checking for the false, negative, positive, and the fixation losses. As I said before, it has a cloud-based storage system. So from where you can retrieve all the reports and the information, you can even transfer this data to any other surgeon. You want to take an opinion of other surgeons, or probably you want to email the data, you can just do it. And the data of all the reports, it can be easily accessed through the test control device, and it's stored on the cloud-based storage system. So I would just like to show this small clip about the newer virtual reality, what you see, device. This is the headset, which is mounted on the head, and this is the test control device. There is an adjustable headband that goes, and it helps to fixate it onto the head of the patient. The patient response pattern, the patient usually clicks when the patient sees the stimuli. The test control device helps you to feed the entire data of the patient, like the eye, which is going to be tested, the strategy, and the kind of threshold test that you want to do. You can even do a screening test with this. There is a gaze tracking system that you see here, and it accounts for all the fixation losses and the false positives and the false negatives, etc. So in this AVA, what we are offering right now is the 30-2, 24-2, and a 10-2 program with the algorithms. The ELISA FAST, we call this as an ELISA FAST. It's the screening test. It is similar to the Humphrey, for the CETA FAST that we do on a Humphrey field test. And there is an ELISA ZEST. The ZEST is the Zippy estimation of sequential threshold. It is one of the methods of how you do a threshold testing. This is similar to the CETA standard, and there is obviously a full threshold testing that can be done. The device, AVA, has its own normative database. The parameters have been included are the age-corrected mean for all the test points. The probability limits have been set for total deviation for the mean defect and the pattern standard deviation. The values for 5%, 2, 1, and 0.5% significance levels are being demonstrated. I will also show you the test report. How does it look like? The blind spot location tests have been done, and the location of the blind spot and the fixation losses catch trial method, they have been found to be very accurate in this AVA. Well, I'm not in a position to put the exact figures right now because it's into the peer literature, but it is real, it's into the peer review process. That's why I can't put up the data here, but it has been found to be very effective and very accurate. the retest variability tests have been done for the central, for the middle, and also for the peripheral visual fields, and the mean threshold values and standard deviations have also been calculated for that. And the linear regression analysis, it really shows that with the increase in eccentricity, there's a corresponding increase in the variability, and with the increase in sensitivity, there is a decrease in variability. This again is in sync with the previous test results that we have got with the standard perimetry devices like Humphrey. So this is how the visual field looks like. On the left, what you see is the AIOS visual field by Elizar, and on the right, what you see is the Humphrey by the Zeiss. So you can see there's quite a similarity between the visual field reports. These are the field reports of the same patient that I'm trying to show you here. And the ongoing development for this device is about the progression analysis and the EMR integration. The advantages that we have with these devices that I just highlighted before was that the first thing is that it is portable. You can do it even in a supine position. If you have a patient with any neck deformity or a spine deformity, the patient need not sit all the time. You don't need a specific space to do this. It can be done even in the waiting room where the patient can perform this test. There's no learning curve. It's easier for the test administrator to do that. There is the accurate detection of visual field defects is there. It's very cost effective as compared to other standard automated perimeters that are in the market as of now. And it's definitely helpful in rural areas. You can screen your patients, you can send your reports to the doctor, to the ophthalmologist, or to the glaucoma specialist at a tertiary center or at a higher level, and you can get the reviews and the feedback, and you can treat your patients accordingly. It allows a lot of postural freedom, and especially for this in the post-COVID situation, when you have, the patient can even wear the mask, and the test administrator can stand at a considerable distance and still do the test. So these are certain advantages that come up with this. The suggested reading that I would like to say, if anybody's interested in reading about perimetry.
Yeah, mathematical fix.
So this is what I actually wanted to offer right now, because this is one of the latest advancements in this field of virtual perimetry. Thank you so much. I would like to address if anybody has any personal queries on my email ID. Thank you so much.
Thank you so much, Dr. Narang. That was fantastic. And I think utility is indeed going to be far reaching. So I look forward to speaking more about it at the panel discussion, which we will have after three more talks. So our next speaker really needs no introduction. It's Ashwin Agarwal. And if you haven't noticed, there's been a theme in this session. This Agarwal name has been mentioned quite a lot of times, because really they've been incredible innovators. So the group at Agarwal Eye Hospital, Susan Jacob, Ashwin Agarwal, of course, Amar Agarwal, and Athiya, who often doesn't, come to the podium, but is really a gifted surgeon as well. So they're always pushing the envelope, trying new techniques, teaching the world. I think that's really quite amazing, is that they figure out these techniques and then really kind of simplify it for all of us to learn as well. So without further ado, I'd like to introduce Ashwin Agarwal, who will be talking to us about a very, very complex situation, which is management of congenital cataract. So all yours, Ashwin.
Deep, thank you so much for the kind words, but I hope my screen is visible and I'm audible.
Yes, okay. Absolutely.
I do have financial interest with ELISA, but none of it pertains to my talk today. I do have to mention that some of these cases are not, they're very, very graphic in nature. So viewer discretion. But okay, so here goes. When we see a Marfan, or when we see a subluxated or a congenital deformity like this, a lot of us do think, what do we do next? And we do wonder whether we should put the lens in the bag, or how do we go about it. But we've come out with a 10-year literature on actually doing glued intraocular lenses in these cases. But the way I do it is very, very interesting. And I think that's something that even if 1% somebody learns it, it could help, because we've got a lot of literature and published articles on this as well. So basically, I'm making my partial thickness flaps and making a sclerotomy about 1 millimeter behind the limbus in these cases. in these cases. And using the same sclerotomy, I'm actually doing a lensectomy. But sometimes, when these subluxated lenses are too subluxed, they flop around a lot and they move around. So one tip and trick I'll tell is hold the bag with the left hand, and that really holds the whole lens. Even if you don't have any zonules in place, you'll actually be able to bring out this nuclear matter, all the cortical matter from inside. Then perform your anterior vitrectomy, use some Kenalog if you need to, and perform your complete anterior vitrectomy. After which I do perform my glued intraocular lens. People, if they wish to do a Yamane, that's also fine, but intrascleral haptic has definitely proven to be much more stable in the long run in these very, very young patients. So what basically I'm doing is externalizing one haptic, then using a handshake technique, externalizing the second haptic. Some more often than not, you'll see that you can tighter these haptics in size and actually bring them to centration. I did use some meiotic over there to get the pupil down and right in size. Once I've done that, I've used my Gebauer-Chariot's tunnel to kind of tuck these haptics into place. And pretty much end of this case is here, and we've just some stromal hydration, put the glue under the flap and close this wound completely. This is one of the cases of a complicated cataract in a young congenital patient. Here's another one, a different one, but let's have a look at how we manage this as well. So the basic construct here is I don't know what's happening, honestly. This is just a white cataract right in the middle, and once you go ahead and remove this rexus, once you perform your rexus, you're able to then start seeing what kind of comes out of this. Is it a plaque? Is it a nucleus? Or is it a cortex? Is it fibrosed capsule? I'm not sure what it is. So after I've done my irrigation aspiration, in this case is mostly after any of the soft nuclear matter comes out, most of the cortex just comes out pretty easily with Simcoe cannula is what I'm using in this case, because I did not want to go ahead and push in irrigation at that pace and jeopardize my bag. So, but what I also found was this thick plaque of fibrosed capsule slash fibrosed nucleus of sorts, and it was stuck to the capsule. Fortunately for me, it didn't actually create a PC rent, but I was unable to bring this piece out with anything. I tried to dissect it, I tried to stab it, I tried to cut it, I tried to irrigation aspiration on it. It just wouldn't move. It was a thick plaque right in the middle. So I actually had to hold it with one hand and cut the piece into two halves, after which it would burp it out in some fashion, and the other one was basically removed with using microforceps. Once this is done, you check your irrigation, check your cortex all around again, and make sure that you have your rexus in place. Once you know that your rexus is intact and your bag integrity is all the way ensured, then place your lens inside, and you can choose to do the YAG later on, but I like to do my PCCC with using a vitrectomy cutter then and there on the table itself, so that I know that the patient will have some amount of vision as soon as the recovery is there. Otherwise, 2-3 weeks at least before you can do the YAG. So that's one of the reasons why I like to do this on table then and there. I place the lens in the bag, especially being a young patient. Another patient which is even more tricky and interesting is one of PHPV, that is persistent hyperplastic primary vitreous. And this is an animation which I'm showing, and I'll show you the real case after this. So basically there's a fibrovascular stalk right in the middle. And this fibrovascular stalk really needs to be ligated before you can actually cut it. You can't cut it. You have to cauterize it before you ligate it. And that's basically what I'm trying to show here. Which is what you have to do in these cases. So I'm just showing you an animation before I show you the actual procedure, what I did. So you can see that fibrovascular stalk right in the middle, the white one with the vessels flowing all around it. And here I've taken my electrodiathermy and doing a cautery of it. So you can see that the blood has not yet stopped. So I really need to make sure that it's completely cauterized before I can take this plaque out. Once this is cut, I still have to cut away all the vitreous adhesions that are there around it. And now I have a central area of visibility using which I'm doing my glued intraocular lens procedure. And it's kind of tricky because at these times you really want, the patient has come to you with the white reflex is what really is troubling the parent. And I know that the vision restoration is not in our hands in these cases, more often than not, because it all depends on how well this patient will recover from here on end. But once you see that stalk, don't try and meddle with it too much, because that can bleed and it can basically abort your case right then and there. So I try to remove as much of blood as I could and hope for a regression to happen on that stalk itself. Uh, Post which I have placing my intraocular lens in using a glued intraocular lens, so that there is no more surgery required for this patient in the post after this, at least for the next 8-10 years, before which we have some opportunity of vision to grow back for this patient. Once I've done that, I'm again doing my Gibbons Chariot's tunnel and placing my haptics under that flap. My flap is now closed with glue and conjunctiva closed as well. Uh, this is pretty much the end of the case. Unfortunately, the patient was too young for me to take a clinical picture post-operatively and was not from town, so has did not come back post this. I did though follow up with that patient and has been doing pretty well. Not, I wouldn't say 6'6" for sure. This is another patient that looks similar, but is not so similar in its own sense. Uh, well, this actually happened very recently. It was an 8-month-old child, and if you see here is a fibrous membrane on the pupil, but more importantly, the anterior capsule did not look normal to me at all, because the minute I tried to puncture it, it just wouldn't go through. It was completely fibrosed, and I was only able to do it with a blade, with a 15-degree blade, and after which I had to literally cut it all the way around. I tried to, extend using a forceps, but it just wouldn't uh, go through in any format of its own way. The complete fibrosed capsule over here we have here. And how much ever you use a bimanual technique, you use a single handle technique, it didn't budge whatsoever. In fact, the zonules were getting weak. So what I tried to do now is make a new entry from below, from my subincisional area, and completely cut it all the way around. That was the only way I was getting past this thick anterior capsule. Again, using any maneuver did not help over here. So again, use my bimanual technique of using a micro scissor and removing this anterior capsule. Once this is done, I still don't know inside what's the scenario here. Okay, so I am taking out all the cortical matter from this case, but if you see here, the posterior capsule is completely thick fibrosed with a vascular membrane. But I fortunately did not find that fibrovascular stalk that was hitting the posterior capsule at its center. So I'm pretty sure that this was not a case of PHPV, but there was a fibrous bag over here, which needed to be cut with a vitrectomy cutter, and that is what exactly I went ahead and did, using a vitrectomy cutter. And as soon as I did that, I was able to see a beautiful red glow that gave me a little bit of satisfaction that this patient actually might end up seeing something. I did leave this patient for the time being in this fashion, because the lens is in place, the central visual axis is completely okay. And I just wanted to measure that there was about 4 millimeters in length, and it was a decent amount of opening that I had given. So uh, hopefully that this patient would be able to see something at the end of this. Uh, just in interest of time, I'm going to stop my presentation. I do know that there are other speakers as well. So thank you very much.
Thank you, Ashwin. You did not disappoint. That was, again, really quite amazing surgery in these incredibly challenging eyes. So, and so much different anatomy, you really don't know what to expect. So you have to have plan A, plan B, plan C, etc. So very well done. Moving on with our program, we next are going to hear from Dr. Renato Ambrosio. He is our fearless leader. He's the president of the International Society of Refractive Surgery. He is going to deliver a recorded presentation. And again, another world's expert in keratoconus imaging. And so here we go. Over to Renato.
Yes, thank you. I'm just going to share my screen as Renato's presentation is with me.
Hello, I am Renato Ambrosio, and it's my pleasure to collaborate with this great meeting with my friend Ashwin Agarwal. And we, in this international conclave for ophthalmology, we have moved to international virtual meetings, but we hope soon to be together live and in presence again when we have this pandemic of the COVID-19 controlled. One of my favorite topics is keratoconus imaging, and I'll give you a quick update in the 7 minutes. This is my financial disclosures. And of course, I have to acknowledge my colleagues in BRAIN, which is completing 10 years, Brazilian Artificial Intelligence Networking in Medicine. When we talk about diagnostics for connectage, I think it's wise to understand the wisdom from the art of war. We need to understand what we're looking for, what are the enemies. We are looking for early diagnosis, prognosis, classification, and staging, more detailed follow-up. Patient orientation will be definitely guided by all this information, and treatment guidance, since refraction, contact lens fitting, and surgery and management complex cases will definitely benefit from imaging. Imaging comes from anamnesis and slit lamp biomicroscopy, which is the standard, up to the most complex genetics that's still not available. But we have to understand the topography and tomography distance. The surface evaluation with topography with a placidodisc front surface reflection is very important for the tear film analysis. We have 3D architecture analysis, front and back elevation and thickness mapping with tomography. And even tomography can go beyond with layered tomography, including the ability to measure epithelium thickness. And this epithelial thickness map is now with layers like Bowman's layer. This was pioneered by Dan Greinstein. We have great contributions with the OCT with David Huang and Yan Li. And now with the group from Bangalore, we have Bowman's layer topography. This is huge improvements that we have seen to benefit the imaging for getting information for helping the patient. We call this multimodal corneal imaging. It's important to understand data acquisition parameters. We need to have accuracy and understand the difference between accuracy and precision. Accuracy is how the measurements are close to the reference value, which is the gold standard. Precision is the repeatability. And with this information, with the robust parameters, we can develop displays, and artificial intelligence comes in a very important tool for us to get this tons amount of information. The multimodal imaging gives you a lot of information, and artificial intelligence with a very emotional and clever intelligence, we have to be keen to use this data to help the patients. So we have, for example, the Pentacam, which is a multimodal imaging with axial length and ocular wavefront beyond the Scheinfeld rotation tomography. We have different tools from the Pentacam family that give you a lot of information. And you can look at this information based on the histograms on the normal population and the disease population, which is included keratoconus and other situations like angle closure glaucoma. You have the Bellin-Ambrosio display, which is over 10 years now, which gives you an enhanced evaluation for tomography. But we have even gone beyond with Pentacam Random Forest Index. Michael Bellin has also a great contribution with the progression display with ABCD, in which the change from the baseline value is compared to the deviation from the standard deviation from the precision of the measurements in a normal and a keratoconic population. So you see if this change is significant from the baseline. Also, enhanced diagnosis for laser vision correction is very important, because we've gone beyond the detection of mild forms of keratoconus, and we've gone beyond considering topography and frontal corneal surface to the understanding of ectasia susceptibility. We have to understand that ectasia susceptibility is not exactly the same as form-through keratoconus, which is a recognized major risk And based even on tomography in this great series from Steve Schallhorn, you see that about 1% of the cases with no ectasia in a very large series of LASIK cases, these cases may have foam fruits keratoconus or even keratoconus appearance in tomography. Even though some cases with a normal tomography, they can get ectasia, 30% in this series. So we have to understand what is foam fruits keratoconus. Foam fruits keratoconus may be defined as the eye with an abnormal topography from a patient that has normal slit lamp and distance correct vision 20/20. Steve Kleiss, differently from Yaro Rabinovitz, in a more deeper understanding of foam fruits keratoconus, would say that the fellow eye of the normal topography of those asymmetric cases, and those cases we call very asymmetric ectasia cases, we have learned tremendously from them. We have the very nice understanding from the Myanga-Tinel on topographic criteria, and this very nice theoretical separation that we see here is what we're trying to achieve with artificial intelligence. Interestingly, the systematic review, there is no criteria for defining subclinical and foam fruits keratoconus in 95 studies. We have to understand there's no consensus, and my humble contribution is that ectasia susceptibility is a better term to define foam fruits keratoconus. And we count that when you saw this first time, the patient had LASIK in the left eye, no surgery in the right eye, would be stable in the right eye with no surgery and qualify for LASIK, but the left eye developed ectasia. And we published in 2010 the tomographic and the ORA biomechanical parameters. Today, we can see that with the Corvis integrated with the Pentacam, which includes a random forest index to TBI, which will make it much easier to develop the understanding of ectasia susceptibility. So when we think about diagnostics for keratoconus, we have to understand what we're trying to approach, how we do that with multimodal imaging, understand artificial intelligence is key for understanding susceptibility and understanding susceptibility based on the impact from surgery, and of course, telling the patient not to rub the eye. It's always the concept of going beyond, making progress, not over, not forgetting what we have understood, and is a true revolution that's still in evolution.
I think the voiceover has, there's no voiceover. Ashwin, are you there?
Ashwin, you're muted.
Ashwin, you're muted. I think that's why, yeah,
No, I'm there, but
because I think he is speaking. It's okay. I think he came to the end of the session.
but the voice was still going on. It was
Going on just for last 10 seconds.
okay. Not sure why that happened. You want me to play it again, or
No, it's fine. I think it's Dr. Deep.
No, I think, I think he was talking about the Violet June campaign
right.
in Brazil, which is a wonderful campaign to alert people that eye rubbing is quite a significant risk factor. And I believe that was a picture of his beautiful daughter. So
Yes.
over to you, Ashwin.
All right. So Renato, thank you so much. I know you're not with us right now, but thank you very much for doing everything that you do for keratoconus and for ophthalmology overall. Now coming to the last talk for the day, and then we're going to have our special panel discussion. But the last talk is always the best, and Ashraf Armia from Egypt is with us, and he's going to talk about pinhole pupilloplasty in challenging cases. Ashraf, all yours.
Thank you, Ashwin, so much. Thank you for the invitation. Thank you to be among this distinguished panel in this great meeting. So I'm going to share my presentation. This technique is not new, but I'm going to highlight what the great Ammar innovated is a pinhole pupilloplasty. I used it in a lot of my cases in my practice. In the challenging where I can't do anything, this would be the best solution. So I'm going to highlight two cases. These are my financial disclosure. So as I said, the credit goes to Ammar and Perea for this great innovation. I'm going to present two cases. The first case is occlusive pupillae with a topographic astigmatism. And it was a traumatic cataract, neglected, and I thought that this technique will help me a lot in the post-operative results. And the second case, it will be bioptic technique using the toric IOL in cases of high irregular astigmatism or intractable astigmatism with a pinhole pupilloplasty. So the first case, it was a male patient, 55 years old, came to me to restore the vision in the right eye after trauma since many years, ending in occlusive pupillae with just hand motion. The other is completely normal. On examination, the cornea was clear with a shallow anterior chamber. The retina was normal by ultrasound. And his pentacam revealed high astigmatism. I thought it's not recommended to put a toric eye in this case because I'm going to do a lot of trauma to the iris to do this case. So as all know that in these cases it's not an easy to open the pupil, but it takes a lot of time. I'm not going to highlight it a lot, but you see as it's thick, and in these cases the iris is also not a normal iris, and a lot of the structure of this iris is completely lost. When you remove a lot of membranes and the pupil, you are going to do more trauma to the occlusal pupillae muscle. And this means that the pupil is not going to restore its function normally. And also another trauma that I made with the dilation of the pupil with the iris hooks, that needs more trauma to the iris tissue. So you need to do a good rexus and put the IOL in the best place, which is very important. But after I remove the iris hooks in these cases, I found that pupil is totally irregular. And this is the trick, that you should specify where the pupil with the Purkinje image. And you do the fourth group pupilloplasty, which is my technique in the all iris surgery nowadays. It makes the operation very easy and much faster. But the most important that you find your center of the pupil, and you put a scheme where you are going to put your sutures and where you are going to close your iris defects in this iris to reach as small as you can pupil to maintain the central vision using the centration of the Purkinje image, and it's going to overflow the high astigmatism of this patient. And this is what I achieved in this case. It was a dramatically different post-operatively, as I'm going to mention now. So this is how the patient came to me with the vision hand motion, and after many years, and he reached uncorrected visual acuity 2014. Despite he has an astigmatism, which I didn't prefer to put toric IOL in these cases because I didn't know how the operation was going to go. Another case is a very interesting case. It's a female Syrian, age 30, came to me for just a refractive correction of her right eye, and the examination of the right eye found that she has an iris globoma congenital, and the other is completely normal. But this eye is normal posterior segment, and the cycloprojection refraction for the patient was +7 sphere, was -5 cylinder, and her best corrected visual acuity was 0.4 with +6, -4.5 cylinder. So I asked Pentacam to do a femtoLASIK, which is, I was not happy because of the iris globoma and how glare can achieve the post-operatively. But I did that Pentacam for the patient. I didn't feel happy with this Pentacam, with the astigmatism. It is not symmetrical, the bow tie and the posterior elevation for this patient. So I told the patient that I don't prefer to do refractive surgery for you, but we can do another thing. We can close the globoma to maintain a good vision post-operative. We can use a toric IOL in this case to achieve at least a premier refractive surgery correction. So in these cases, the iris, the capsule usually not an easy to open. So I open it with the cystotome. Very important in these cases to have a good size of the rexus centrally to maintain stability of this toric IOL inside the bag. This is very important. And because you are going to do pupilloplasty, so you need a good centration of the IOL and a good size of the rexus, because you are not going to see it again. Very important also to put a CTR in the high toric cases, maintain a good stability and decreases the capsular phimosis postoperatively, which I use most of my cases with the high toric lenses to maintain a little bit stability post-operatively. So after I put my CTR, I mark the patient as normal, and I put my toric IOL, and I finished it irrigation and removing the viscoelastic behind the IOL to maintain a good stability of the IOL. Then I start to close the iris. Very important to see your PKG image. And the first suture of the iris is the best one, and this is the most important. I always say that this is the first step if you want to do a good pupilloplasty. The first suture is the most important, because the Purkinje image centrally and closing the iris, maintaining it centrally all the time. And then I closed the discoloboma by 3 sutures by the same technique for through pupilloplasty, which is very easy technique. Everyone can reach it easily. And after I close, always look for the Purkinje. So this is how it becomes. It was a 0.4 with +6 and reach it like this post-operatively. So I achieved the best what I want for the patient. So the idea of this technique is performing a pinhole pupilloplasty help filter the stray light from the periphery of the cornea in cases with a higher order corneal abrasion. It also blocks the distorted and unfocused light rays and isolates more focused central and paracentral rays through the central aperture, thereby reducing the abrasion and enhancing the visual acuity and its image quality. It also, the pinhole devices mitigate the impact. What was known for the corneal ablation, the pinhole visual acuity is an indicator of the visual potential of an eye and of corrected visual vision of the patient can perceive. A lot of contact lenses, corneal inlays, pinhole, intraocular lenses help to achieve the pinhole, as Booker said, and the pupilloplasty procedure facilitates the pupil reconstruction and help to achieve an adequate pupil contour size and shape. And my home take message that achieving a pinhole effect can narrowing down the pupil size. The pinhole pupilloplasty significantly improved the visual acuity in patients with higher order corneal ablation by allowing the passage of light through the central pinhole area and reducing the aberrations of the optical system. And also, very important trick, use your Purkinje image. Images helps locate and create a central of the pupil. Thank you for listening. And thank you for being with you all.
Thank you so much, Ashraf. That was absolutely fantastic, right? Taking these very aberrated corneas or aberrated eyes and doing quite a simple maneuver to help patients see and see without correction. So it's really a tool that we've heard 2 speakers talk about now. So we can modify the iris with pinhole pupilloplasty, or as Professor Dick was speaking about with the IOL. So it's time for our panel discussion now. And I think we're going to talk, we actually have some time to talk about quite a few topics. And let's start with the pinhole concept. And I'd like to direct the questions to Dr. Dick and to Dr. Armia in terms of how small is too small. And I want to also introduce Susan Jacob, who is joining us, who is extremely knowledgeable in all these techniques as well. So we'll bring all the speakers back. And I'd like to hear your thoughts about, of course, you have wonderful central vision, central acuity, you reduce aberrations, but can you tell us about patients, the peripheral vision? And if you do this procedure bilaterally, is that an issue, or should you only do it unilaterally? So if we could hear from, let's start with Dr. Jacob, because she's very knowledgeable about this as well, and then we'll move to the other speakers. So please, Susan, tell us your thoughts.
Thanks, Deeps. I think Dr. Amar actually did a study where he checked the autoperimetry of these patients post pinhole pupilloplasty. and found that really it was not decreased too much. The patients were able to move out freely, and the outer perimetry was almost completely normal. So I think movement or mobility of the patients is really not affected by doing a pinhole pupilloplasty. I think maybe Burkhard Dick will also add some comments to that with his pinhole IOLs. The other thing is that I think pinhole pupilloplasty has some advantage over the IOLs in the fact that you can actually center it over the Purkinje image. So you can get it closer to the the visual axis than you could with the IOLs, because IOLs just center with the bag and you may not get it exactly over. So that's an advantage that this technique does have. Ashwin, would you like to add something?
Yeah, I think the whole pinhole concept is totally revolutionary in its own way, and I do believe that in the future, and I don't know, Burkhard, you can support me on this, that I do believe that most cases are even a little bit challenging. We're going to think about easier techniques like pupilloplasty, especially when you have corneal issues which aren't resolvable, or if you have any media issues that are not resolvable. You're going to look at pinhole as a concept overall. Burkhard, would love to hear your comments on that as well. You're on mute, Burkhard.
Sorry. So of course I agree fully with you. It has great potential, no doubt. But currently we have a preset, so to say, inner diameter at a mask with the IOL, and this has to be overcome. It is good already, but it's not perfect, as we all know. And I can imagine also to use this concept, as I said, in natural lens as well as in pseudophakic eyes already, but not in the cornea, because I don't think that the cornea camera inlay is the good way. It's the lenticular issue, because you are closer to the nodal point from a physical optical point of view. And also what we know is there is a bigger discussion now, also within the company Accufocus, if we will stick to the size of 1.3 something rather than enlarging it, also changing the mask diameter. And of course, if you can laser it with a femtosecond laser into the eye post-operatively, according to the focusing patient, that is of course the next step ahead. But we have to handle what we have currently available. And Deep asked me about also the peripheral, the visual field. Yes, it is decreased on the left eye or on the eye, the non-dominant eye. It's slightly, but it is effect. But interestingly, Pablo Attal and others, and I can confirm it also clinically, the retinal level, so to say, is increased in terms of the perception of light. And that is something that is done more by the brain. That means that the brain adopts for the less light that is coming into the eye if you are doing this binocularly. Because if it's monolateral, of course, because of binocular summation, it is diminished to zero, as Pierre already said. But binocular, of course, it's another issue, and that's something that was astonishing for us. But what we have to take into account also is, of course, that we have some kind of fibrosis. So also what comes into play is here the size of the capsular axis or capsulotomy, yeah, and the shrinkage and the fibrosis that occurs there, because it can also then act as similar as a pupilloplasty. And I fully agree. Ideally, of course, we center it, but obviously centration is not that big issue with a small mask. And I love more the terminology of small mask rather than pinhole, because pinhole is something that we understand, of course, but the mass of conservative eye doctors think they are using the stenopaque thing and translate that immediately, and that has a negative attitude, so to say. Positive in terms of seeing what the patient can see. So bilateral works, but I wouldn't recommend that on an offensive way, because if people start, they should start with monocular on the usual way rather than handling it binocular.
I would like to add one thing to this, to the pinhole pupilloplasty. There is a concept, that we need to center it around the Purkinje reflex. But there is another point to it, that it is not a subject fixated coaxial light. It is, you are doing the surgery under block. So when you're doing a surgery under block, you need to be very careful where the Purkinje is lying, because actually what can happen, you can have an eye rotation, and if you try to center on that decentered thing, you're going to be in soup. So you have to be very careful when you're doing a pinhole pupilloplasty, aligning it on the Purkinje reflex, but again, keeping in mind, it's not a subject fixated coaxial light. It is under the block. It's just a coaxial light of the microscope that is coming, and you're trying to center around it. The other thing that I would like to say around for the optimal size of the pinhole pupil, we have analyzed this, and what clinically what we have found that anything beyond 1.5 practically is not very good, and anything beyond 2.5 you tend to lose out the effect of a pinhole. So the defocus curves and analysis what we have done practically have come up to be very well, even with the pinhole pupilloplasty, and as Burkhardt said, with the IOL itself, because the concept is the same. It's a pinhole, so it will give you a defocus curve, but you need to have a proper centration for that. So that is one thing which has to be taken care of when especially doing a pinhole pupilloplasty.
And I think one of the best ways to do that would be just to do a coaxially sighted light reflex before surgery, preoperatively mark it on the cornea. You would have a little bit of parallax despite that, but that would really help to a large extent.
And Dr. Jack Holliday has come up with his pinhole device. He has designed this, and starting from 0.5 to 3.5 millimeters. He has a disc kind of thing that you can put in front of the patient's eye before the surgery, and you can just find out that, okay, whether the patient sees best with 1.5 or 2 or 2.5, something like that. So that really might be helpful for patients. We need to evaluate that clinically, but yes, that's there.
Thank you so much, Priya. And I wanted to, bring back to Dr. Mahipal and Dr. Rajesh also into the discussion. Wanted to ask them directly, we have so many corneal cases going on nowadays, and especially after the lockdown, there's been so many backlog of these cases coming in. I wanted to ask you, there is this whole concept which I think Benny Jeng spoke about of endothelial cells and stuff. George and Dr. Jacob, if you can also join in on this discussion, it would be nice to have that with you, and Deepinder, you also. The endothelial cells, they're talking about endothelial cells just injecting endothelial cells into the anterior chamber, and how does that work? Does it work? Does it not work? I think that's something that the crowd really gets fascinated about and wants to know more about every year. Dr. Rajesh, you want to go for it?
Yeah, actually, it's definitely looks wonderful, and it will be very good for the patient if it, if it keeps working. I mean, if it's reproducible in all eyes and consistently, if it works. I don't have a first-hand experience of doing this, but based on studies and based on the works that have been presented by Jord and by Benny, I feel that, I mean, this is what is going to be the future, and it will make life very simple for the cornea surgeons, I guess. I mean, more of anterior segment surgeons will enter into the field of cornea, I guess.
Right.
There's a question, there's a very interesting question that comes to my mind when we talk about CECs and, injecting them. Of course, we know that you have to position the patient, face down. One of the rare situations in corneal surgery, we generally ask them to be face up. However, Joe, this is for you. What happens if some of these CECs actually land on the trabecular meshwork? Would you have an ICE kind of syndrome where they go and block the trab and then maybe even grow over there and cause secondary glaucoma? Is that even a possibility?
Yeah. So when you're injecting the cells, when we started doing cell injection on the animals about maybe 3-4 years ago, you got to bear in mind that you're injecting a lot of cells, like 1 times 10 to the power of 6. Right, which is way more than you actually need. And the reason why is that when you scan these animals at day 1 or day 2, what you actually see is an endothelial duplex. So the cells are accumulating on them. So I tell people it's like, if you think of like a cup of tea and you pour tea bags into a tea and you look at how they collect down the bottom, that's exactly what you can see at OCT. When you scan the same animal 1 week later, these cells have all formed a monolayer. So what that means is that all those cells that were in the duplex have basically fallen off. Where are they going to go? They're going to go through the trabecular meshwork. Okay, so that's the only way of basically clearing. So IOP monitoring, done by us, done by Shiguru's group, done by other people that are working in this area, have not shown that, we've never shown that basically the IOP has actually changed as the cells are definitely passing. But the cells are definitely, the excess cells are definitely passing through the trabecular meshwork. The question about whether those cells proliferate, you have to bear in mind that when you inject the cells, that's why if you look in that paper, you look at one of our papers, it's very important to understand the genotype of the cell that you're injecting. So one, you must inject cells that are chromosomal and analogous to normal endothelial cells. Two, all the proliferative genes that you've basically switched them into to proliferate have to be switched off. Okay, so that's why, that's one of the key things about this. If you inject cells that are still proliferating into an eye, of course they're going to proliferate. You're going to get basically a tumor there. So that's why it's important that when you do this, is that your cell culture technique, whichever technique that you do, I mean, you know, the 3 techniques that have been approved for basically clinical use, they're slightly different with how they basically work. But essentially, when you look at the sequencing of the cells after they've gone back to their state, which we are injecting them, in our technique, we switch off all those proliferative markers. So in fact, you're injecting pretty much bona fide cells inside the eye that are not proliferative. And the third point is that you have to always remember that your aqueous humor has natural substances to stop proliferation of your endothelial cells. So you have TGF-beta, you have a lot of things in the anterior chamber to actually stop your cells from proliferating. And the reason why it happens in eye syndrome is because the cells undergo a phasic shift to convince them to basically proliferate. So those 3 things will keep them in check. And if you do staining studies, I mean, meshwork, you're lucky. I've seen cells been on the iris, they go through the zonules, they go all over the place, basically. So you will get, and I mean, when you flip them, when we flip the animals to 3 hours and stuff, if they do move, the cells do shift to basically one side. And I have a very nice OCT on one of the first cases I did, where the cells all moved to one side. And when we looked at the animal at day 1 week, half the cornea was thick, half the cornea had completely cleared up because the cells had all basically slopped to one side. So those things, you know, you do see, that's why posturing and face down posturing is really important.
And for how long do you maintain the face down posturing?
3 hours. 3 hours. The key is you have to give a ROCK inhibitor. I mean, the 2 caveats of this, I mean, I'm not sure whether you'll be able to do this in all cases, I have to say. The key caveat that we found and we published on is that you have to have a Desmet's membrane intact. If you don't have a Desmet's membrane there, basically certainly the cells I've seen didn't really stick in any serious manner. I mean, you can statistically see there's some improvement, but from practical circumstances, I wouldn't say that worked. So you have to have a Desmet's membrane intact. And the second is that you must inject them with a ROCK inhibitor. Otherwise, the cells don't basically stick.
John, I had one query. Like in a case of a long-standing vitreous hemorrhage, many times we do get ghost cell glaucoma, right?
Yeah.
Can we have a similar kind of a thing, a late onset glaucoma in such cases? I mean,
Well,
how long?
Yeah. This is a good question. I mean, I haven't seen, we've used our cells in primates and also in rabbits. I mean, rabbits is always short-term because they're under continual immunosuppression because of the xenogenic studies. But even in primates, the longest one I think we had was like 3 to 4 months. And we never saw any, you can't see anything. AC is absolutely quiet basically afterwards. And even when you check them on OCT after basically 2 to 3 weeks, the AC is actually pretty quiet. You can't see anything. What I don't know, and one of the things that we're hoping to study now or soon is what happens if you inject the cell and they have an iris defect. I mean, it goes back to the talk on pupilloplasty, right? What happens if they have an iris defect, right? Would you do cell injection or would you do basically a DMEC? I mean, will the cells fly back into the vitreous? Will they go back? Will you get PVR or something? Will you get an ERM? I mean, I don't know, but I think that's something that I think we can certainly study because we can track the cells inside the eye to really see some idea of how they go. And then it'll usually give you some idea that maybe a contraindication could be these aphakic cases where there's not a proper diaphragm between the anterior and the posterior chambers and stuff. These cases, maybe you have to avoid basically doing cell injection. But I think these are things that I think are worth studying to basically really get a better idea of what cases that will be more used to basically doing this. But I think your post-graft cases are ideal because they have a nice Desmet's membrane. They've had a previous PK. You wipe off the endothelium. You just put your injection on them and inject. And these cases are not that easy to do DMEC on. They have higher risk of complication. But cell injection could be a very easy way of doing that surgery.
I just wanted to ask one question, Deep and Ashwin. And both the people have shown about pinhole pupilloplasty as well as pinhole IOLs. What about in eyes with iris coloboma? I mean, do you think they still work, or, I mean, because the fixation for the patient with the iris coloboma will be a little different. So, Dr. Maipal sir, would you like to answer that, or Dr. Bokard, would you like to
After
answer?
the answer, I would also like to add one point.
Yes, sir. Dr.
But,
Maipal.
no, obviously you see when you are having a coloboma, there could be associated coloboma behind also. And as it is, if there is, the fixation becomes eccentric. So I don't know whether a pinhole pupilloplasty and fixing it on the purkinje is going to be helpful or not, because the patient, you are knocking out the eccentric viewing that the patient has, or the eccentric fixation that has. So I'm not sure. I have still not adopted the pinhole pupilloplasty in my regular practice, but maybe those who are doing, they could let us know. But maybe this could be one of the indications, or rather indication where you may not want to do that.
Maybe you can put the Jack-Faraday instrument in front of the eye of the patient, the pinhole, and you can just let the patient see. But I don't think so. It should be.
No, but does
no,
anyone have experience of doing it, and then what are the results?
We have
the pinhole IOL for saturation.
Dr. Armia wants to say something. Yeah.
Yeah, in this last case of the clear lens for the iris coloboma, I did the pinhole testing before the operation. And this is what I achieved with the pinhole. So this is this is why I offer for the patient to do the clear lens, toric IOL, and the pupilloplasty, because I achieved a good vision correction with the pinhole testing before the operation.
I have some experience on only iris coloboma, and yesterday only in my OR I was doing one pinhole pupilloplasty in only iris coloboma, where I did cataract surgery, put an IOL in the bag and did that. So if there is no iridofundal coloboma, then it works very well. But if there is an iridofundal coloboma, then I don't think it is advisable.
And Ashraf mentioned in his case that the posterior segment was normal.
Yeah.
Dr. Maipal, I have another question for you. You use both the Humphrey and the virtual perimeter. What is your take on it? Could you give us all your insights on that?
Yeah, so we just acquired the devices and we are using it, and I think it's a good device for nowadays. You had the home care coming up in the patients who wouldn't want to come in the COVID time. And the reliability, the specificity and the sensitivity is pretty good. The only thing is that as time passes on, we will need to have more normated data that should be available with this device. But otherwise, I think I congratulate you for having this device made. Reasonably very portable, affordable, I would say, and also easy to do for the patient to understand. And the environmental conditions need not be so. You can easily take it to the house of a person, or to have people who are not wanting to come out, or even those who are incapacitated for any reason, that would be there. I think the era of taking devices next to the patient is coming, whether it is home try-on for glasses, whether it is autoref, whether it is tele-ophthalmology, whether it is fields, etc., whether it is fundus imaging. And we are not too far when artificial intelligence comes in, and people will have maybe when you are going to a mall or something, you could have your picture taken and artificial intelligence telling you whether you have diabetic retinopathy or not, and you need to see an ophthalmologist. So I think things are moving, and this is definitely a positive contribution towards the patient's safety, precaution, and the flexibility that it offers to you to get the fields done. Sometimes patients can't come, and you can do that. So I think great, and we are getting good results. I think you people have replaced most of your Zeiss perimeters with this. We have bought a couple of them, and as we get more experience, we are running a couple of trials. So we'll see as to the total outcomes that are there, and then work around with it.
And Professor, how long does it take to capture the field in this virtual reality-based system? What's the time?
Deep, you're asking about the timing for a test?
Yeah.
Yes.
Yeah. How long does it take to capture?
Yeah, we have done the screening test and the threshold test. It's almost similar. It's just like, it's almost similar to the Humphrey. Like you take about 7 to 8 minutes for a regular threshold testing, and for the screening, it takes around 3.5 minutes or 4, maximum 4. Yeah. So it's the time slot is almost the same. There isn't any statistical difference between the Humphrey and the AVA.
Perfect. So Ashraf, I know you have a question for Priya. Can you go ahead and ask that question?
Yeah, Priya, this machine is a portable, so it is on battery level, yeah?
Pardon? I didn't get it.
It's a battery or electric?
It is a battery operated device.
Okay.
Yes.
So as we know that
it can be charged. It can be charged, and with a single charge, you can do about 10 to 12 tests easily. Yeah.
Yes. So as we know that in most of the field of vision machines are on electricity based, and the electricity base, it is stable for the luminosity for the patient. Does the battery level or the intensity of the battery will going to change the luminosity for the patient for perception of the light to detect the field of vision?
Oh, okay. I did not understand. I'm trying to understand. Can you just?
It's saying if the battery goes off or the battery is dying, how would you change the luminosity for the patient or keep that standard?
Yes.
Okay, you're saying about that. Well, I'm not, to be very frank, I've not come across this. So maybe, I mean, what I feel is that it's just a new device as of now. So we have been just recharging it and using it. But maybe, yeah, that's a practical point. I haven't come across that yet.
Because you show two pictures, the Humphrey and your outprint.
That's
I felt that,
yeah.
Yes, there is a difference in the perception of the light in both printouts. Some of them are 0 and some of them was plus.
I understood what you're saying. I understood what you're saying. See, it is basically, now this is a very technical question that you are asking me. It is basically the background illumination and the stimulus intensity that you are talking about to me. But having said that, I understood now what you're saying. The background illumination and the intensity, it is always in collaboration with the intensity which is being depicted behind. So this is a very technical thing which has been done by Vamsi. He is the engineering person behind it. But yes, the correlation remains the same, what you get into a Humphrey device. And there are certain changes that are made, because here in a virtual reality, what you don't have a bowl. It's not a curved kind of thing. It's a flat screen. So there are certain technical changes that are done by that, and I'm not the right person to describe that. But yes, that has been taken, and it is in correlation with the Zeiss device, with the perimetry Humphrey device. Yeah.
Doctor, thank you, Priya. Thanks, Ashraf. Dr. Namrata and Dr. Rajesh, I think you guys use the intraoperative OCT the most probably in this whole webinar right now. But can you tell us what?
I think Deep also uses intraoperative.
But okay,
not nearly as much as Namrata. Please, that talk was fantastic.
My question is, in case you do use it, what are those few surgeries that are wow? I mean, which are the ones that give you the wow factor with that intraoperative OCT? I think that's a question that the crowd really wants to know. And anybody else wants to chip in and tell which are the surgeries that you definitely don't want to be doing with this?
I think surgeries I think which we definitely want to be doing would be pediatric keratoplasty, because children you cannot really examine, and cases like Peters and Namley or corneoaradic scars, etc., which you can see on the intraop OCT microscope, you can actually make out where the iris is, and whether there are synechia present or not, etc. So it's really useful there. Then DMDs, your Desmet membrane detachments, I know you can handle them otherwise also, but it kind of just makes you more, it makes you more clever to know where it is getting detached and what is the configuration and what type of detachment is this. And then apart from this, I think it has a great role to play in DMEC. In DMEC, especially with hazy corneas, where you can't see the S stamp. S stamp has done a great trick, because with S stamp you can actually make out what is the orientation. But in hazy corneas, in our part of the world where we are doing a lot of DMEX on hazy corneas, it really serves well. And of course, ocular surface disorders also, because it tells you what would be the thickness of the panis and what would be the thickness of the cornea underneath. Lots of time these chemical injuries have underlying cornea which is not that thick. It's quite thinned out, and so it helps you to take a decision as to whether you would want to do a lamellar graft or just a surface procedure.
Right.
So it does help you a lot, and for us it's become like, because it's perpetually there, so I don't know what we'll do if it is not there. So it's
I guess you,
I
Madam,
have.
I guess you missed out a couple of surgeries which you and me keep doing very often. That is ultra-thin dissect also, wherein you see that the fluid has disappeared. If it's still there, then you can inject more air so that fluid disappears. You massage and do all that. Then DALC also, at what level you are working.
yeah, ALK, I think
Whether
it's
the
really
stroma is. And another point I would like to mention here is that in cases wherein you have very high vault, wherein ICL vault, wherein you are rotating the ICL, so on the table you get a rough idea that once you have made it vertical, whether the vault has reduced significantly or not, and whether you have to keep that ICL or you have to expand that. So these are a few more things.
yeah.
I think we can also use it for posterior polar cataracts. I think that also gives you a great
Absolutely.
look. And we are presently using it for the lenticule extraction. So sometimes you get a large bubble OPL. You can find out whether it's above the lenticule or there is a breakthrough and things like that. So we be getting some good images. Don't know clinically how important it would be, but you do get good images in even the lenticule extraction.
Right.
Yeah, I think it's interesting to see that those who have the device swear and say it's the thing they don't want to miss any longer, and the rest of the world who cannot afford this say it's not helping me at all. Forget
Right.
it.
It's
It's only additional work or so.
So, Dr. Dick, it depends on whether it's the government's money, which taxpayers' money, which Namrata and Rajesh has for free, and whether we have to buy it on our own in practice. So I think that's going to be the big differentiator.
So we don't have to buy it on our own. The government buys it for us, so we have the luxury of having it. But I'm sure we would be happy to do without it if we had to buy it on our own.
So, Namrata ma'am, do you do pediatric keratoplasties without the IOCT also? I'm pretty sure you do it, right? It's not that you completely insist on the IOCT for
No. Our
every
problem is that all our current microscopes, operating microscope, and all the ORs have been replaced by IOCT.
I see. Now, Dr. Michael, sir, I completely agree with you now.
Completely agree. No? So it's our money going there, right?
We have to, we've just...
So by default, you have to use it. I see.
Namrata, you have to thank the honest taxpayer of India for all your presentations. Financial interest.
No, we have about 7 of them, I think, already in place. So we have no choice, and that's
But at times it takes a long time to capture the image. That's
a long time to capture,
so,
and you do need
size also is
you do need a person who knows how to handle it, because at times it doesn't focus on what you want to focus. So you take time to focus on that particular thing and then see. And actually, what you see in the operating microscope, the image is much smaller. So what you have to depend on is the image which is there on your operating microscope on the computer. So every time you keep peeping out also, and to see a more magnified image, because actually the picture that you get in the operating microscope is quite small.
Great.
Yeah. So I think we have crossed our 8 o'clock or our last minute time. Dr. Namrata, I would love for you to actually conclude the session and take us through it for the next day. What's coming up?
So thank you so much, Ashwin. I would like to thank everybody. I would like to thank the ISRS, the American Academy of Ophthalmology, and all the speakers who did great presentations, all the panelists who had a great panel discussion. And we do have other sessions which are coming up tomorrow and day after. And I'm sure Deep and Dr. Bukardik, you would again collaborate with us on the same platforms. And it was a pleasure to have you. And we can't thank you enough, because without you all, it would not have been really possible. Thank you so much. And of course, I
you.
would like to thank our own people also, Ashwin, for coordinating this. And would like to thank Dr. Mahipal Sajdev, the president of AIOS, who's been so proactive throughout the year. And he just lets us be. We know whatever we do, he supports us. And I think that's a big thing. And of course, Rajesh, who's always been there in all the endeavors that we have done together. So thank you so much. Thank you, everybody.
Thank you, everyone.
Thank you. Bye.
Bye.
Bye-bye.
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 Thanks.
Thank you, everybody.
Bye.